So next we'll introduce Dr. Rob Venick, who is a hepatologist here at UCLA. He's a pediatric hepatologist, but he also is a subspecialty consultant for us in the adult congenital heart disease program. And this is, I think, a good example, the relationship we have with Dr. Venick, of the kind of multidisciplinary, cross-departmental collaboration that's needed in order to have a successful ACHD program. So Dr. Venick's going to talk to us about Fontan liver.
Thank you and good morning, everybody. It is truly a pleasure to be here. I don't have any disclosures. I'd just like to say on a professional level, I have great respect for all of you in the room, the cardiologists, cardiothoracic surgeons, the intensivists, and on a personal level, I have nothing but gratitude towards teams here who care for these patients and feel privileged to be a part of this. Dr. Abelhausen and I participated in a meeting at the Heart House a little bit over a year ago, and some of what we'll cover in the next 15 minutes has to do with some guidelines that will be forthcoming and are in the process of publication. So these are the topics that I'd like to cover, kind of the pathophysiology, why patients with Fontan physiology develop Fontan-associated liver disease, some of their symptomatology, kind of highlight the importance of early identification and risk stratification for these patients, talk about ways that we monitor and screen them and pitfalls in our current technology, and then therapeutic options from a liver perspective. And we'll close with some of the limitations and limited data with combined heart-liver transplant. So normal liver physiology is such that the portal vein provides the majority of the blood flow into the liver. And at the microvascular level, the blood circulates through the liver via sinusoids. Normal pressure in the sinusoids for most of us hopefully is around 5 millimeters of mercury. In patients with Fontan physiology, and Dr. Lin, I thought, and previous speakers have done a great job of highlighting just the sheer number of patients as cardiac and cardiothoracic care has improved. A number of these patients are certainly reaching adulthood, and then this recognition of Fontan-associated liver disease has certainly emerged. And I think the two driving factors or common underlying problems here, why a patient would develop Fontan-associated liver disease, have to do with elevated central venous pressures. We heard a little bit about this problem with non-pulsatile flow and passive congestion in the liver. And then the second just being kind of this chronic underperfusion or chronic hypoperfusion of the liver as a result of decreased cardiac output. So under the microscope, what that translates into is that the sinusoids become dilated. This you can sort of appreciate in the central part of this low power slide. There are a number of red blood cells kind of congested in here, and we would see a much sort of tighter sinusoidal picture here in a normal liver biopsy. The other thing that really stands out and makes this quite interesting to hepatologists is that congestive hepatopathy really lacks inflammation that we see throughout almost all other forms of liver disease, whether it's viral hepatitis or non-alcoholic fatty liver disease or alcoholic liver disease. So a lot of this is very interesting to us from a study standpoint, and I think also highlights the fact that the therapeutic measures for these patients are often different than for patients with other forms of liver disease who develop cirrhosis. Over time, what this concept of chronic congestion can lead to is scarring in the liver, and that's highlighted in this trichrome stain. The blue is essentially collagen or fibrosis deposition. This tends to start in the sinusoids and then tends to expand towards the central veins, and when it becomes bridging from one central vein to the next, we're sort of kind of in a pre-cirrhotic state from a histology perspective. How this translates clinically is that many of these patients are actually in a good way, in 2017 discovered as we're screening for them. So this may be incidentally on laboratories or imaging. Clinical manifestations may include hepatomegaly, an end-stage liver disease patient with a failed Fontan, occasionally may have a shrunken liver, although that's a lot less common as the liver becomes cirrhotic. Ascites is often not uncommon, and some of that may have to do with protein-losing enteropathy as well. Portal hypertension manifests by splenomegaly, low cell counts, low platelet and white blood cell counts in particular, esophageal varices, and then this risk or development potentially over time of hepatocellular carcinoma, which is something that can occur with any form of chronic liver disease. Hepatic encephalopathy and impaired synthetic liver function, i.e. coagulopathy, are more advanced and unfortunately less common in this population than in other forms of chronic liver disease. When we are seeing these patients in clinic in a multidisciplinary fashion, one of the very important points is how far out is a patient from their Fontan. We have good data from multiple ACHD centers around the country that the further out one is, approaching 20 plus years, you see the odds ratio of developing Fontan-associated liver disease continues to climb. Along those same lines, we see patients that are 30 plus years out from their Fontan who have very little liver disease, and perhaps their cardiac function, as shown in some series, may be better than other patients. So those are two kind of important ways to stratify risk of developing Fontan-associated liver disease. Ways that we can screen for this, we mentioned laboratories, and we'll look in a little more detail at that, imaging, biopsy, and then this is really how the field of hepatology is moving to non-invasive biomarkers, and there are some very interesting and exciting biomarkers. I think it's fair to say that in this population, none of these are validated, at least in large numbers, and there are some scoring systems, and we'll highlight just a couple of those towards the end of the talk. I wanted to show this. This would be kind of a typical laboratory profile. It's a relatively small paper here, but very representative of patients who are 10 to 15 years out from Fontan, which are the main abnormalities we see are a mild elevation, typically in AST or ALT, and then the GGT, which we like or prefer over alkaline phosphatase. Those are the two that stand out. Most of these, though, are relatively mild, and I think another important point is that many of the patients who are on Coumadin, looking at their INR as a measure of liver synthetic function is not something that we can utilize, so we may look at fibrinogen or factor V or factor VII levels. Albumin, because of PLE issues, may also be difficult to gauge. The thing or the limitation with laboratories is that it does not do a good job, as you can sort of appreciate here, in differentiating cirrhotic patients from non-cirrhotic patients, and that's a theme throughout the panel of liver function tests. Along those same lines, not only is there a poor correlation with biopsy-proven cirrhosis, but over time, these laboratories don't tend to move in a common direction where we grade fibrosis from 0 to 4, with 4 being cirrhosis, and we really don't see, as you can appreciate here, even with small numbers, we don't appreciate a change over time in numbers. So while the liver function tests, and we do follow these periodically, tell us some information, they certainly have limitations. One of the laboratories that we also will follow in patients 10 plus years out from their Fontan is alpha-fetoprotein. And alpha-fetoprotein is a decent but very limited marker for screening for hepatocellular carcinoma. This has its limitations in very small malignant lesions in the liver and not being able to detect those. And it also has limitations in fibrolamellar variants. And then, of course, up to 20% of patients with HCC may not produce alpha-fetoprotein. So having said that, again, this is something that we can follow and maybe follow within an individual patient over time to look at their trends. What's the optimal cutoff point in this population, and the sensitivity and specificity is certainly something that we still need more data on. So that then brings us to imaging, and listed here are kind of the three major modalities of imaging: ultrasound, CT scan, or MRI. If you ask a hepatologist, if you're seeing a patient with a failing Fontan, which modality would you prefer? It'd be an MRI, and it'd be an MRI with EOVIS contrast. That's a means of differentiating focal nodules and evaluating for focal nodular hyperplasia versus hepatocellular carcinoma. But that's not practical for everybody. Ultrasound certainly has its benefits, as shown here: non-invasive, cost-effective, et cetera, but very limited based on a patient's volume status. A dual-phase CT, we have to be very cognizant of another complication that we heard a little bit about, which is nephropathies in these patients. And then the MRI, again, some of these patients with hardware and pacemakers may not be practical. So imaging also has its limitations in that it tends to overestimate degree of fibrosis. If you looked at this multi-center study of 50-plus Fontan patients over 15 years out from their Fontan, over half of them were described radiographically as cirrhotic, and up to 20% of them have these focal nodules that we discussed. Now, 40% of the patients who are biopsied have less fibrosis than was estimated on imaging, so we know that, we appreciate that, the imaging may overcall a lot of these things. Our field is trying to move towards non-invasive ways of grading fibrosis, and elastography, both in ultrasound and MR, has become sort of a very commonly ordered test and very useful in following patients with viral hepatitis and NASH. But unfortunately, in this population, it's very limited. Elastography is by central venous pressures, and we don't have great correlations with degree of fibrosis with this imaging modality. Imaging, as we said, can be useful to look at these lesions, and I won't really go into that in more detail, but when we see them, oftentimes we'll discuss with our radiologists and look at our degree of suspicion and say, is there a lesion there that needs to be biopsied? Has it changed over time? Does it have suspicious features? And then we'll kind of rely on IR-guided biopsies if there is such a lesion. So that brings us to biopsy. We can use biopsy to go after these targeted focal lesions. But biopsy of liver in general, and we do this jointly oftentimes in the cath lab under the same anesthesia. If a patient has ascites or a coagulopathy, that may need to be done by interventional radiology, but biopsy is really our gold standard for staging fibrosis, which is a very important point in the long-term management of these patients, whether it means changes in their cardiac care or movement towards transplantation. In terms of treatment for cardiogenic fibrosis, just in broad themes, and you all could speak much better to optimizing cardiac function than I, but from a liver standpoint, we talk and advise patients about avoidance of a second hit to the liver. So moderate or abstinence from alcohol, good weight loss, nutrition, exercise, that can be challenging in this patient population. Avoiding other medications that can potentially lead to drug-induced liver injury, screening for viral hepatitis, making sure our patients are immunized. For those who had cardiothoracic surgery before the early 90s when blood banks were screened well for hep C, the use of direct-acting antivirals, which offer a great chance for cure for hepatitis C these days. And then really managing complications of Fontan-associated liver disease. And so we have really solid guidelines for other forms of chronic liver disease from the American Association of the Study of Liver Disease. For portal hypertension, for example, we know when we ought to screen these patients with endoscopy, put them on medications such as beta blockers or isosorbide dinitrate. There are not such clear guidelines in the failing Fontan population. We do think that the prevalence of varices in this population is up to 20%, but of course that depends on how far out patients are. We also think that bleeding from varices is less common in this patient population than in other forms of chronic liver disease. So it really needs to be an individualized decision. It's hard to make a blanket statement in terms of endoscopy and so forth for these patients. Ascites management, same things. We have very good guidelines for other forms of cirrhosis. A first-line treatment for cirrhotic patients with ascites would be sodium restriction and diuretics, but again, those decisions need to be made in a multidisciplinary fashion based on patient volume status and cardiac condition and so forth. Paracentesis is something that can be offered. TIPS has a very limited role, oftentimes because of abnormal anatomy in these patients. And then hepatic encephalopathy, not something that we see as prevalent in this group of patients versus other forms of cirrhosis, but I think rifaximin is the medication that would be our drug of choice for these patients because you don't see the volume changes or electrolyte disturbances that one would see with the use of lactulose, and then limitations in protein intake. HCC treatment, I won't belabor this, but bottom line, we have guidelines when we do have patients with focal HCC, and those guidelines are based on the size and the number of lesions and can incorporate resection, transplantation, RFA, TACE, and medications such as sorafenib. And then finally, just to wrap up with our scoring system, we know that if we kind of look at do patients have varices, ascites, splenomegaly, and thrombocytopenia, and we give each of those a point. Patients with VAST scores greater than 2, as shown here, and this has been validated by other single centers, have higher risks of developing hepatocellular carcinoma, requiring transplant, or succumbing to their disease. The same thing, there's the MELD, with the exception of the INR, so the MELD score is used to prioritize patients awaiting liver transplant, and it incorporates bilirubin, creatinine, and INR. If you take the INR out of that, because for many of these patients they're anticoagulated, we know that MELD scores have predictive value in the need for heart transplantation or in mortality risks for these patients. So there's some non-invasive biomarkers shown here. I think all of these need further investigation, but the FibroSure panel may be the one that we're most excited about, and that incorporates alpha-2 microglobulin and apolipoprotein A1, as well as LFTs. I think finally with transplantation, all that I would highlight is that we really have somewhat limited data from 87 to 2010. You can see 90+ thousand liver transplants, 67,000 heart transplants, and 97 combined heart livers. In the past 7 years, that number's more than doubled in our country, so this is becoming more of an issue here at UCLA. Within the last 5 years, we've transplanted a number of combined patients. These patients, if selected properly, can do quite well at the 5-year mark. They often are in their 30s or 40s and have 5-year survival approaching 70%. Many of them have kidney issues going into transplant that need to be carefully screened and monitored for, and the inclusion of the liver may offer an immunologic benefit for the heart outcome. So again, with that, thank you very much, Jamil, and have a wonderful day.